Over to you, sir.
Okay. Thank you. We are starting, huh, madam?
Yeah. Okay.
Hello, good evening, doctors. Welcome to this webinar on experience sharing program on managing PPH, case studies from labor room. This program is brought to you by Heathrow Healthcare, an innovative pharmaceutical company. Heathrow Healthcare, the journey began in 1993. We have got 25 years of excellence and 36 state-of-art manufacturing facilities. Heathrow Healthcare has 300 plus products in portfolio and presence in 126 plus countries. With 21,000 employees globally, Heathrow Healthcare has largest closely held pharmaceutical company in India. It is among the largest manufacturers of ARV, APIs and FDFs in the world and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's webinar, case studies from labor room. We have got Honorable Speaker Dr. Jnaneswari TL with us. Welcome, Madam. Dr. Jnaneswari is MBBS MD DNB at FIG. Madam is Vice Chair KIAGE, EC member BSOG, obstetric laparoscopic surgeon from Bengaluru. Welcome, Madam, and over the session to you.
Thank you, Mr. Pramod. Thank you for the kind introduction. Thank you for giving me an opportunity to talk on this very important topic, which is an overview of postpartum hemorrhage. Can you change the slide, please? The next one. Postpartum hemorrhage is a very daunting event. It is defined as the loss of at least 500 ml of blood following a vaginal delivery or around 1,000 ml of blood following a cesarean section. It is a very common occurrence and it can even occur in women who are not at all at risk of a PPH. It is a leading cause of maternal mortality in the low-income countries and a primary cause of nearly 1/4 of all the maternal deaths globally. Next slide, please. Even though it's a very unfortunate event, it's very sad that it's also very common. So it is a leading cause of maternal mortality, accounting to about 35% of all the maternal deaths. It is more in developing countries, as all of us know. And the global incidence of PPH is, it is something like 14 million women suffer from PPH. And it is as much as high as 2 to 4% after vaginal delivery and 6% after a routine cesarean section. Out of 38% of the maternal deaths are due to PPH, and 27.7% of the global deaths take place in India, and 2/3 of these are due to PPH. So India has an unexpectedly high maternal mortality of 540 per 1 lakh live births. We are striving hard to get it to less than 72. Let us hope we'll do it fast. Next slide, please. What are the leading causes of postpartum hemorrhage? It is usually due to uterine atonicity, which is the most important cause. The next is trauma, that is called traumatic PPH, where you have cervical lacerations, lacerations to the uterus, and rupture of the uterus, uterine inversion there. Then you have tissue retention, most probably a part of the placental cotyledon or some part of the membranes are retained into the inside the uterus post-delivery. That can cause postpartum hemorrhage. And last, but a very important cause could be because of coagulopathies. Next, please. What are the clinical findings in a postpartum hemorrhage? Abdominal tenderness, not very common unless you're looking in right sides of a broad ligament hematoma or a uterine rupture. Circulatory collapse, a very difficult and a very fatal sign. Increasing abdominal girth, loss of uterine contraction, that is the loss of uterine contour or the tonic hardness of the uterus after its delivery, maternal tachycardia, and vaginal bleeding. Usually we should go from below up. Starts with vaginal bleeding, leading to loss of, because of loss of uterine contractions, leading to maternal tachycardia, then circulatory collapse, and then increasing abdominal girth and abdominal tenderness. Now, this is a grading of a PPH that we can see in the table here. If you have a blood loss ranging from 500 to 1,000 ml, which is usually 10 to 15% of the blood volume of the patient, it is a compensatory shock that you can see there. There's hardly any change noted in the blood pressure. And the symptoms of mild symptoms of patient can be a little uncomfortable, can complain of mild dizziness, slight tachycardia around 100. Your pulse rate would be around 100. Then anything which is more than 1000 ml to 1005, between 1000 to 1500 ml, you will have a slight fall in blood pressure. Then the patient will start complaining of weakness. She'll have sweating, tachycardia. Coming to moderate loss, it is 1500 to 2000 ml. Here there is marked fall in blood pressure. Systolic can go as low as 70 to 80. Patient will become restless. You can start seeing pallor. Patient starts having oliguria. If you can get her from this end, you can get her. If you let her sink and go to severe postpartum hemorrhage, that is where the chances of you losing the patient are very, very high. You can go up to 2000 to 3000 ml of blood loss, profound fall in blood pressure. Then patient will collapse. She'll have air hunger, and then of course there will be renal anuria. Next slide, please. A patient has PPH. So what is the first thing you do? First thing you do is you ask for help, put into IV large bore cannulas, rush in fluids on both the sides, look for the uterine tone. If the uterus should be rock hard after delivery. If the uterus is not hard, ask your least intelligent assistant in the labor room to come and stand and massage the uterus there, and use the other persons like your staff or your assistant to start in an IV line, start giving uterotonic drugs, send in for blood parameters, look out for a CBC, last for a coagulation profile, also look at your creatinine and urea. Then first you check for the uterine fundus. If it's above the umbilicus, just go on massaging it gently so that it evacuate all the clots. And then ultrasound is a very important tool which you can have in your labor room. Put in an ultrasound, check for any retained products of retained membranes or retained placental cotyledons. Then explore the tract, look out for any vaginal tears, cervical tears, broad ligament hematomas on abdominal ultrasound. Start simultaneously, resuscitate the patient, give a good fluids like ringalactate and normal saline, along with drugs. Drugs are your most important friends here. Start with oxytocin. We would usually give prostaglandins, then ergometrins also. Then afterwards, if it doesn't subside with anything, bimanual compression, bimanual massage of the uterus, then go in for a balloon tamponade. Otherwise, tear trauma, suture them, explore them, suture it. Otherwise, if it's a cesarean section, do a B-Lynch, do stepwise devascularization of the uterus. And then always, if it is a vaginal delivery, first thing you do when you're doing all of this is put in a catheter, also drain the bladder. So once the bladder is drained, amount of PPH also becomes less. And the other thing is you'll know the status of the kidney instead of keeping on asking for serum creatinine and other things. Next slide, please. Also ask for blood parameters also, coagulation profile there. We have so much of uterotonics also already there that are there in the market, but what is the rationale behind the development of carbetocin, which is a new heat-stable formulation? The advantage of carbetocin is that it is available in room temperature and it is convenient in a convenient vial form. Oxytocin and ergot alkaloids should be kept in refrigerators to avoid degradation, while carbetocin, on the other hand, is stable even at room temperature. Heat-stable formulation of oxytocin is not currently available. That is what they found an analog in carbetocin. The previous formulation of carbetocin was supposed to be stored at 2 to 8 degrees again, but now this is a new drug which is heat-stable carbetocin, which need not be refrigerated. So it is of great importance in resource-poor nations where they don't have accessibility to electricity all the time, where you don't have refrigeration facilities all the time, where you cannot maintain cold chain at all the time. This molecule has a great role. Next slide, please. Now, when do we administer a uterotonic agent? At the time of the crowning of the baby's head. Oxytocin, well, you should wait for the delivery of the anterior shoulder, because once the anterior shoulder comes, even if the uterus contracts, you can pull out the other shoulder easily. At the end of the second stage of labor and following the delivery of the placenta, usually at the delivery of the anterior shoulder of the patient. Prophylactic use is for prevention of PPH. It's also called active management of third stage of labor. And then therapeutic use it can be used as a therapeutic for also management of PPH. What are the molecules available with us? We have oxytocin, carbetocin, ergometrin, synthometrin, misoprostol, and of course, carboprostol also. The next one, please. Carbetocin is the next generation drug for PPH management. It is very similar to oxytocin. It is a synthetic drug, long-acting analog of oxytocin. Therapeutic indication is for prevention of postpartum hemorrhage due to uterine atony. One vial contains 100 milligram or microgram of carbetocin in 1 ml solution for injection. It was created by making several modifications to the oxytocin structure, which helps in prolonging the half-life of the molecule and also reduces enzymatic degradation of the molecule. The next slide, please. These are the differences of the brief characteristics of oxytocin and the heat-stable carbetocin here. Oxytocin, all of us know, is a naturally occurring hormone from the posterior pituitary. The commercially available is a synthetic cyclic peptide form of that. It binds to the oxytocin receptors in the uterine myometrium, which will cause uterine contraction of the contraction of the uterine smooth muscle by increasing the permeability of the sodium of the uterine myofibrils. On the other hand, carbetocin is also a long-acting synthetic analog of oxytocin with agonistic properties. This also binds to oxytocin receptors in the uterine smooth muscle. It results in rhythmic contractions, increases the frequency of the existing contractions, and increases the uterine tone. How is oxytocin given? Oxytocin is usually given IV infusion or can be given IV. Direct IV infusion or a rapid push of the oxytocin IV will lead to hypotension. 5 units is something which we can give direct IV. It acts immediately, almost immediately, and it lasts up to 30 minutes. While an IV injection of carbetocin takes about 2 minutes to act, but it has a more sustained and lasts for around 6 minutes, and it is followed by rhythmic contractions for 60 minutes. The IM dose of oxytocin has a slower onset of action, of course, 3 to 7 minutes, but it can produce longer lasting clinical effect up to 60 minutes. While carbetocin, on the other thing, starts acting at around 11 minutes and can keep it contracted for 120 minutes. The half-life of oxytocin is 1 to 6 minutes, while carbetocin is 40 minutes. All of us know that oxytocin needs to be preserved under refrigeration 2 to 8 degrees continuously to prevent its bioavailability. While for carbetocin, the heat storage conditions can be stored up to 30 degrees in room temperature. Oxytocin is used for the induction of labor. Yes, carbetocin cannot be used for the induction of labor. Oxytocin is used for the augmentation of labor. Yes, while carbetocin is not used for augmentation of labor. For prevention of PPH, oxytocin is used. Carbetocin can be used. For the treatment of PPH, oxytocin is used. And of course, carbetocin is also used for the treatment of PPH. The next slide, please. Next one. There are various studies that have been done, and all of them show that carbetocin is not inferior to oxytocin. You have the WHO champion trial where it is showing it is a double-blinded, non-inferiority randomized trial. It was done to compare the effectiveness and the safety of the investigational heat-stable carbetocin to oxytocin in the prevention of PPH after a vaginal birth. Excuse me one second. And then there were 30,000 women which were enrolled across 10 countries. And the primary outcome shows that with blood loss of at least 500 ml or use of additional uterotonic agents, the proportion of this one that was studied. Next slide, please. So the study showed that the efficacy of carbetocin was the efficacy was around 14.5%. Oxytocin is also 14.4%. Blood loss of more in patients with blood loss of more than 1,000 ml, it was just 1.51%. Here also it was 1.45%. And one patient had an unexpected adverse event in both of them. So the results are comparable. The frequency of blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior versus oxytocin. Next slide, please. A Cochrane review states the carbetocin for preventing postpartum hemorrhage for women who undergo cesarean section, carbetocin resulted in statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. That means if you're using oxytocin, some other drugs might be needed, but if you're using carbetocin, most of the times you don't need anything else. Also, carbetocin is associated with less blood loss while compared to symptometrin in the prevention of PPH for women who've had vaginal deliveries and is associated with significantly fewer side adverse effects. Next slide, please. Next slide. See, there are various organizations that have advocated the use of carbetocin for preventing uterine atoning. WHO has advised for PPH prophylaxis, has advised use any one of the following or only one of the following. This is for PPH prophylaxis. That is oxytocin, but also carbetocin has been included in the armamentarium. Misoprostol, ergometrin, oxytocin and ergometrin fixed dose combination. In Canada, carbetocin is what is advised. In New Zealand, active management of third stage of labor, prophylactic uterotonics is given. FIGO is also given carbetocin, a thumbs up for carbetocin in the use of recommendations for PPH management. Also, Germany and France also advocate the use of carbetocin in their PPH armamentarium. The next slide, please. A few things about my experience with carbetocin is, as of now, for cesarean sections, right from I don't give oxytocin IV directly. I always give it in an infusion. Infusion is a diluted form, takes a little while to act. So if you're giving a rapid IV push of carbetocin, I find it safer. So most of my cases in cesarean sections these days, I have switched over to carbetocin rather than oxytocin. Oxytocin 10 units IM is what I would like to give. So yes, I do notice that there are the blood loss in my patients with whom I'm using carbetocin is a little less. I have not quantified it, but yes, definitely it's a little less. Next slide, please.
Now, coming to this, before we go to panel questions, madam, generally you prefer what route?
I I give an IV. I put it in
IV.
100 ml infusion and I give IV.
Okay. Okay.
I don't give an IV push, 100 ml infusion. For my cesarean sections, for normal deliveries, I still go in for an oxytocin.
Correct. And since how long you have been using this drug?
I have been using it for the past 6 to 7 months regularly.
6 months,
We
yes.
were previously also on and off, but now for sections, this is my preferred drug now.
And you find a distinct superiority in terms of onset of action, in terms of duration of action. Distinct
Uh,
difference, I'll say. I may not say
I
superiority.
wouldn't say a distinct superiority, but it's a more convenient drug to use.
Yes,
Yes, instead of breaking in 3 ampules or 4 ampules of oxytocin and putting it as
absolutely.
an infusion.
And
Here
without
you
any
give one
storage
ampule
requirement.
and it takes care of it, and you don't have to run to the fridge and get. That's
Correct,
one
correct,
advantage.
correct, correct. So practical advantages are more than the theoretical
Yes,
ones,
yes,
as we say.
yes. But it cost again plays an effect. That's one part there.
Coming to this panel question, some of them we had. What is the benefit of using carbetocin as a first-line drug to prevent PPH in every patient, as we say?
Every patient, I don't think we should use it as an every patient, keep it as a reserve drug, but yes, um, it's better. It is slightly better than oxytocin. Other than that's what I said. You have to break in 3 ampules of oxytocin and then push it into an infusion. You can't giving rapid IV infusions of oxytocin causes hypotension that can be life threatening at times. So so you have to run it in an infusion bottle and you have to give an IM injection. Here you can just put it in 100 ml NS and that would do. So that you can for on table, yes, I do.
Yes. And although we can expect PPH in any patient, but any specific patient profile where we can expect a PPH.
Yeah. People with multiple pregnancies, people who have preeclampsias, pregnancy-induced hypertensions, patients with polyhydramnios, anything that over-distance uses, anywhere where you have given a prolonged trial of labor, when the patient is in labor for a very long time, patients with diabetes, all of them, anemia, patients with
Anemia is a major problem
yeah,
in India.
anemia. The reason with anemia is even 500 ml of blood loss the patient will not tolerate.
Correct,
You
correct.
have to plug in that blood loss even before anything happens.
And anemia is fairly common in our country, looking at the.
Yeah. In the rural setup, it is. We are becoming developed very soon, so you'll have developed country problem now in our country. Yeah.
Any experience of using carbetocin in Rh negative mothers?
RH negative you can use.
Mhm.
Carboprost is what is not, sorry, ergometrin is what we don't use.
Okay.
because it causes rapid contraction of the uterus.
Contraction.
It gushes the blood back into the circulation. Carbetocin is something which I use. I do use it. Yeah.
Generally, doctors use oxytocin for labor induction. In such a scenario, can a doctor use carbetocin for prevention?
We can use carbetocin for prevention. This one is, I think, IV infusion, we use only 5 units or six,
Okay.
max is 7.5 units. That is a small dose for the whole of the oxytocin to sit on all the receptors. So you will have receptors for carbetocin to act. It is used.
I mean, you have already answered this. What is your experience about how well it is tolerated?
Tolerance is definitely better. Some patients
Okay.
do complain of a little of headache and dizziness,
Yeah.
but most of they not much of nausea and vomiting on table. So we don't find those patients retching and vomiting and other things. That's
Like some of the
tolerance is much
prostaglandins.
better. Tolerance is
Yeah.
better.
And no, I mean, ADH side effects would also be less looking at the dose.
Yeah, not nausea, vomiting is not there.
Yeah.
Retching is not there. Those things are not there. Otherwise, right. But I do have patients who complain to me of little of headache and
Yeah.
dizziness and things like that.
Suppose if a patient doesn't respond adequately with carbetocin, which can happen, then in order of preference, which is your, I mean, other adulteronics you would use?
See, the first uterotonic I use if it is not contraindicated with this, actually we should be using as a carboprocess, a prostaglandin. Or then the last preferred would be methergine, that's an ergometrin, and then a symptometrin. That is my order, but I usually go in for a ergot alkalite, that is methergine first, and then going for the others because methergine is a wonderful.
Wonderful, yeah. And we have been using it for years, madam.
You've been using it for years, unless the patient is hypertensive, you can't
Exactly.
use them.
Exactly.
In those
Specific for
patients, I usually prefer that, and RH negative, I don't use them. But otherwise, that at least you have most 99% of your patients respond to it.
Madam, is it so that with methergine, the uterus contracts as a whole, and with carbetocin, the upper segment contracts first and then the lower?
Carbetocin acts like oxytocin,
Oxytocin.
that is only during labor.
Labor.
Later, it is methergine, it contracts as a whole. We
Oh,
want the uterus to contract as a whole.
exactly. Exactly.
That is the reason why we give this one. Even postpartum, that is the reason why we give oxytocin and carbetocin. Whatever drug we give, we want the uterus to contract as well after delivery. We don't want the lower segment to be flabby. Everything needs to contract.
Advantage of carbetocin over other uterotonics.
One, it is heat stable, doesn't require any special this one. The other thing is the side effects like nausea, vomiting, retching is less. Ease of administration is there. One ampule is enough for you to put in. And it is a longer way of action. Like the action lasts for around an hour, 60 minutes after one dose. You don't need a continued infusion for a sustained dose.
Okay. And finally, you already told this, it should be kept as a reserve drug. But to conclude your take-home message for the audience,
It is a nice drug. It is a new drug, but I think we shouldn't be abusing it much. All of us should have it with us. Maybe not use it as a first line. If it doesn't respond to carbetocin for your oxytocin, should still be the first line. Wherever there are no places where you don't have refrigeration and you don't have electricity, yes, carbetocin can take over. It is much better than carboprost,
yeah,
definitely, because it doesn't cause those side effects
prostaglandin side effects.
and some you can't even give it in patients with asthma, isn't it?
Yeah,
Carboprost.
yeah.
It causes a lot of severe bronchospasm. In these
Prostaglandin.
patients, this is definitely good. Maybe it can replace carboprost, but oxytocin is still there.
Well, thank you so much, madam, for sharing your experience. That's exactly what our doctors want rather than theoretical references, which they have. Thank you so much. And thanks all the doctors who took time from their
Thank
schedule
you
and
for the
attended this.
opportunity given.
Yes, madam. Most welcome.
I could do justice to the
Most welcome.
topic.
Most welcome. In fact, we always like doctors' own clinical experience because that's what matters to the practicing doctors, sharing experience. And I thank all the doctors who took time and attended this webinar. Thanks once again, madam. And thank you, IT team of Hetero. Thanks, sales and marketing for organizing this. You can sign off, madam, and we'll wish you a very pleasant evening. Thank you
Thank
so
you.
much.
Thank you, same to you, sir. Thank you.